I am talking about in-hospital use of continuous glucose monitoring, evidence, protocol, and implementation from global standard to local practice. At the outset, first, I would like to congratulate Dr. Bansi sir and Manoj Chawla sir for wonderful meeting of Diabetes India 2026, and again thanking them for inviting me and having me in this wonderful symposium. We are talking about Bharat's global footprint, and we are talking about in-hospital use of CGM. So when we are using a point of care device in hospital, we are missing many things. When we are talking about a continuous glucose monitor in a patient who is not in the hospital, and we are talking about identifying hyperglycemia as well as hypoglycemia, but when we are admitting patient in hospital and we are doing only 5 to 6 times sugar checking with the point of care device, of course we are missing many things, specifically hypoglycemia, that to nocturnal hypoglycemia, and also some degree of dysglycemia in terms of hyperglycemia with glycemic variability. And we all know whenever there is a increased glycemic variability, there are chance of long-term complication as well as short-term complication. So we must use the continuous glucose monitor in hospital. So what are the evidences? The ADA 2025 standard of care states the continuation of personal CGM is recommended in hospital patient if clinically appropriate. They are also advocating automated insulin delivery system should be supported with proper supervision, and the key requirement is implementation requires for institutional protocol as well as confirmatory point of care testing for dosing decisions. So in hospital, there are different glucose criteria. For critical ill patient, the glucose target range is 140 to 180, and non-ICU setup, we target glucose from 100 to 80, 100 to 180, and that we have to understand whenever we are applying a continuous glucose monitor to in-hospital patient. There are evidence that support that as compared to point of care device, when we are using CGM, we are preventing the event of hypoglycemia as well as we are preventing time spent in hypoglycemia. Also, we are identifying and treating nocturnal hypoglycemia, and ultimately we improve the experience of patient in the hospital and also reduce morbidity, mortality as well as hospital stay. They are newer technology, they are evolving to support in hospital even ICU use of continuous glucose monitor. There are of course increased economical burden, but data shows that with the use of continuous glucose monitor, we reduce the ER visit by 30%, as well as we are reducing 41.5% in hospital admission with the use of this technology. So how can we use this technology? All the guidelines support that it should be hybrid protocol. Now what is hybrid protocol? We use CGM for trend monitoring, not for absolute value, but whenever there is a hypoglycemia or sugar range below 100, or whenever there is hyperglycemia, glucose range more than 250 or 200, and we are injecting insulin or we are stopping insulin, we have to use point of care device for the validation, and this is called hybrid protocol. Where they are strongly recommended, strongly recommended for trend monitoring, or hypoglycemic alerts, or continuous personal device in stable non-ICU patient. When we require validation with point of care device, when glucose value is less than 100, glucose value is more than 250, and as and when we are injecting insulin on the base of this continuous glucose monitoring data. When they are not recommended as a sole basis for insulin dosing without validation during MRI, during severe hypotension event, or when patient has a skin infection. Patient selection is very important. We cannot use this in ICU when intensive care unit patient has some physiological challenge like edema, hypotension, vasopressor effect, or there is interstitial fluid is dynamic, is changing very rapidly. And we can use in non-ICU general ward patient where it is strongly recommended. It is also recommended in surgery as well as telemetry unit where it reduces the burden of the clinician. How it should be integrated in ICU or in ward setting. First of all, we have to see the trend with the help of continuous glucose monitor, and we have to set alarm for the range either below 100 or below 200. Whenever the nurse is there, they are checking the trends, and if the glucose is below 100 or about 200 or 250, they will do with the point of care device. After confirmation, they will change the dosing of insulin. There are some limitations, of course, and there are some factors that we have to consider. First and most important is lag time. The interstitial glucose and plasma glucose has some lag that we have to calculate. The physical interference, the compression, when the person sleeps with the sensor which is compressed under his arm, the reading may be different. And some medicine like high dose of vitamin C, even paracetamol or hydroxyurea will interfere with the reading of the glucose sensor. In special situation, this will be very, very helpful, especially when the patient is on glucocorticoid, patient who are be changing from IV to sub-Q or sub-Q to oral, and during peri-operative period, they are very, very useful. The most important slide of my presentation, in India, we are very cost-sensitive market. So here we are not utilizing enough in hospital CGM because of the cost restraint, as well as there is no clear reimbursement policy. Even our infrastructure is not proper, and there is a lack of awareness not only in the patient but in the supportive staff as well as in the doctors. So I would add here that Dr. Bansi sir said in 80 Asia Singapore meeting that in India we have three India. First India, who is very rich, super rich, they can afford any technology as compared to US or Europe, but there are also one India who is very poor, where we have to reach with our all resources that we have. In the middle India, they are always struggling whether they are affording or not, but we have to understand that diversity we have to reduce, and we have to make the best technology to reach to everyone. Even our RSSDI guideline also recommend the use of CGM in hospital. They clearly state that highly valuable for assessing glycemic variability and detecting nocturnal hypoglycemia for patient. With that, I would say the future is CGM in hospital to prevent many complications. Thank you for your attention.